So
Yeah.
I know it's a long list, but nevertheless, we'll be discussing something very interesting today, and I believe this session would be worth attending. So, good evening, happy evening, and good day to all of you who have joined from all over the world. And thank you, Dr. Anand Misra, for the kind introduction, as well as Dr. Alok Sahu for inviting me and making me here among all of you. So, to start with the topic, can anybody tell me, or I would say, how many of you have written acute kidney injury in your clinical note today in your ICU round? How many? Can anybody tell me? Can anybody tell me who has not written acute kidney injury in a single patient? In a single patient of his or her round in today, the ICU round, whoever has done. So, how many of you have written and how many of you have not written? So, to make the story short, this is something which we do day in and day out. And I think almost 50% of the ICU patients at some point of time have developed acute kidney injury or acute on chronic kidney injury or anything related to kidney. So, happy evening, everyone. Jai Jagannath. I'm from the land of Lord Jagannath, and definitely with the blessing of Lord Jagannath, let's start with a wisdom quote. By three methods, we may learn wisdom. First, by reflection, which is noblest. Second, by imitation, which is easiest. And third, by experience, which is the bitterest. But I think we all believe that with experience, now, with this in background, the disclaimers, I am deeply involved with Nephrocritical Care Society initiative all over the world. And I am also the director of 360 Critical Care, which is training, teaching the people across the globe for different examinations in critical care. Now, the topic today, which has been assigned to me, is approach to acute kidney injury. Now, we'll be discussing about classification part because it would be something which would be a completely separate class and it would be deviating from the core topic that has been assigned today. Now, today's talk, I will try to provide you a systematic approach to address the issues, to assess the patient, to derive the equation that where is the problem in our patient related to kidney. Lots of conceptual infographics to keep you on your toes and also to understand the concepts. I believe always in 3S, that is sweet, simple, and structured. So it would be full of S. I work more in nephrocritical care, so definitely I will be talking the core nephrocritical care aspects of acute kidney injury. And finally, if we'll be starting with acute kidney injury, what is it all about? So we all know it's not a single diagnosis, rather a syndrome. Acute kidney injury is a syndrome, just like ARDS. The characteristic is it develops rapidly, hours to days, with deterioration of kidney function. Now, the problem with acute kidney injury in our clinical practice, it is often diagnosed in the context of other acute illness. So maybe the nephrologist will be getting the chronic kidney disease patients, patients on dialysis, patients on like the other supportive therapies frequently in their OPDs. But we as intensivists or the emergency physicians, they will be getting the patients with acute kidney injury. And that would not be, I think, I request somebody's mic is actually creating some noise. Yeah, please mute your like speakers. Now, Acute kidney injury is always, most of the time, it- to okay, yeah, okay, thank you. Now, coming to the impact of acute kidney injury, why we are so serious about acute kidney injury and deliberately why we have kept this topic as our monthly webinar talk. It is not a problem related to the patient. It is not a problem related to the hospital. Rather, it is recognized as a major public health problem. This has serious short and long term. Wait, there is still time. Acute kidney injury has not set in our patients. So if we will be having rapid diagnosis and appropriate diagnostic workup, so I have everything in my presentation today. So you will get the mantra which you can tomorrow itself here only in next 30 to 40 minutes. Related to crash syndrome, that was in 1941, and then series of events happened in 1953. There was like the attempt to have the clinical course of acute renal failure. At that time in 1950, it was not kidney injury or kidney disease, rather it was acute renal failure. In 2002, John Kellam, I was very fortunate to meet him last month in Italy in the AKICRT workshop by Professor Claudio Ronco. So he has called for classification of acute renal failure in 2002. Now, 2003, 2004, Bellomo et al. They have classified acute renal failure for the first time, and that was Rifle criteria 2004. Now, just moving forward, that was Mehta et al. Rabindra Mehta. I also met him at Italy. He was also in Hyderabad for one conference. So they are the pioneers of nephrocritical care or critical care nephrology. So they had the Akin definition and classification of AKI in 2007. Now, 2012, there was a collaboration that has happened and that was named as KDIGO, definitions of AKI and AKD. So in 2002, the concept of acute kidney injury, but injury is something which is not a disease per se. So they have named it as acute kidney disease also in 2012. Now, after that, ADQI, the quality initiative has happened, and they have also thought about taking care of the post AKI, like patient has developed acute kidney injury, recovered, and now going into, or there is some or other symptoms remaining in that patient, some residual dysfunction is there. So how to tackle that? So that was also discussed in 2017. Now after that 2019, there was again one attempt to change the definition little bit of acute kidney injury, non AKI, AKI, something like that. And then In 2021 also, there was some attempt by one other group. So this is something in short. We started from 1941, acute renal failure in crush syndrome, to 2021, and today we are in the 2024. Now, this is something we need to remember. So it is right now happening.
Recording in progress.
Acute kidney disease, acute kidney injury. There is normal kidney disease, chronic kidney disease. Now we'll be discussing all these things. There is no kidney disease is the big segment here. There is no structural criteria to like make it. There is no kidney disease, and the GFR is more than equal to 60 ml per minute per 1.73 meter square. Stable creatinine. We are happy. So that we are all like today, we are having no kidney disease. Now there is another section which is a very like a small section here, AKI. So here what happens? It has been divided by two criteria: functional criteria, structural criteria. Now the functional criteria, just remember, it is the creatinine or GFR. Structural criteria, where there is damage to the tubules, glomerulus, the collecting ducts, the ascending loop of Henle. So these things would be the structural criteria. Now in AKI, there is mainly the functional problems: increase in the serum creatinine by 50% within 7 days, or increase in the serum creatinine by 0.3 milligram per deciliter within 2 days, that is 48 hours, or oliguria. So there would be creatinine, urine output, but there is no structural damage as such in acute kidney injury. Now, in acute kidney disease, it would be AKI, or the GFR would be less than 60, or decrease in the GFR by more than 35%, or increase in the serum creatinine by more than 50% for less than 3 months. So the whole episode would be less than 3 months. So it would be acute kidney injury disease. And structural criteria, there would be some component of kidney damage which will be less than 3 months duration. So that is acute kidney disease. Now coming to the CKD. CKD is all about more than 3 months. Remember, GFR would be less than 60 ml per minute per 1.73 meter square, and there would be kidney damage which is still persisting for more than 3 months. So this is the disease spectrum that we can have in our patients: acute kidney disease, acute kidney injury, chronic kidney disease, and no kidney damage. In a time frame, you can see 48 hours, there would be some amount of injury happening here, and that would be persisting for 7 days. It is acute kidney injury. From 7 days to 90 days, it is acute kidney disease, and from 90 days onwards, it is CKD, from the date of the first injury that happened on 0 day here. Clear? Now let's start thinking about how to classify AKI. Now, over 30 definitions of acute renal failure or AKI is there in the literature, but 3 most important classifications as a trainee or as like a practitioner we need to remember or understand are Rifle classification, Akin classification, KDIGO classification. Now let's start with one by one. Don't worry, this is not for like you all. This is just to symbolize that we are going to start with the Rifle classification. Rifle criteria: Acute Dialysis Quality Initiative, ADQI 2005, and this is the criteria. That is GFR criteria, urine output criteria, and all these Rifle: R is for risk, I for injury, F for failure, L for loss, E for end stage kidney disease. Clear? Now coming to the risk, it would be again divided or classified on the basis of GFR criteria, urine output criteria. 1.5-fold increase in serum creatinine or GFR decrease more than 25%, urine output less than 0.5 ml per kilogram per hour for 6 hours. Injury, it would be 2-fold. The first one, risk, is 1.5-fold, then 2-fold, then failure would be 3-fold. Easy to remember, 1.5 to 3. GFR would be more than 25%, more than 50%, more than 75%. Now, in the failure, here what happens? The creatinine comes here in the third part. What happens here? Creatinine more than equal to 4 milligram per deciliter, or if you will be getting the patient for the first time, acute rise in the creatinine more than equal to 0.5 milligram per deciliter compared to the last day. So you can also keep in the failure section. And here your urine output less than 0.5 for 6 hours, less than 0.5 per kilogram per hour for 12 hours, less than 0.3 ml per kilogram per hour for 24 hours, or you are getting anuria for more than or 12 hours. Now, loss would be complete loss of kidney function for more than 4 weeks, that is 1 month, and end stage is CKD, more than 3 months, 90 days. So this is the first classification which has definitely made its presence felt, and that has changed the way we thought about acute kidney injury before. Now the implications for acute kidney injury rifle criteria. If you are getting the rifle criteria RIFLE down the grade, there is increased length of stay in the ICU, increased length of stay in the hospital, higher mortality, lower renal recovery, and you all would be finally losing your two viable kidneys. That is all we don't want. So lot of like brainstorming happened how we can like identify the risk factors that the patient can develop acute kidney injury later on. Now, was all well with rifle? Wrong, because rifle has so many limitations that we will be discussing now. So that was not well accepted in the elite class of researchers as well as practitioners. It is not predictive. It classifies AKI only after it is established. You can see the classification is only based on the GFR, creatinine, and urine output based on the time frame. So it is not predicting that yes, this patient will be developing the loss or the failure after 1 day, 2 day. The urine and the creatinine criteria are actually unbalanced. Different outcomes occur within the same class. Maybe the creatinine is normal, but the urine output is actually decreasing to like great extent. That can happen in the same class. Same thing that your creatinine is very high, but the patient is still pouring what? Like no urine. That can also happen. So you are confused in which class you are actually putting that patient who is in your ICU. Now, the urine output criteria can be modified or altered if I am using diuretics, high dose of diuretics, if the patient is in diabetic insipidus also. So there are so many confounding factors that we cannot clearly say that my patient's urine output is in the criteria or in the zone of risk or injury or failure. Now, there was also some criticism how the ICU, how the nurses, how the healthcare providers are measuring the urine output in the ICU for the study. So that may be inaccurate. Nobody seems to agree on what is the definition of baseline creatinine. For me, maybe 0.5 milligram per deciliter creatinine is the baseline or normal creatinine. So it is not a universal accepted number up to our patients at the bedside. Creatinine levels may be affected by factors which do not affect outcome. Yes, if you will be very much hemoconcentrated, if you will be having some or other like rhabdomyolysis feature, if you are having some or other drugs like cimetidine, cimetidine can cause pseudo AKI. We all know because it will be inhibit the release of creatinine to the tubules, and that's why the creatinine level will be high. So it's not like there is some functional damage. Rather, it is only the drug which is inhibiting the secretion of the creatinine to the tubules. Now, the risk criteria for creatinine may not be sensitive enough to keep us on our toes. Now, all these things they require true GFR estimation. But What we are doing at the bedside is the estimated GFR. So estimated GFR cannot be equal to the true GFR to a great extent. And this criteria of rifle, they have never attempted, or they have not attempted to distinguish between different etiologies. It is pre-renal cause, this is post-renal cause, this is intrinsic renal cause. This has not attempted to distinguish. So these are something very hard critics for the rifle criteria. Now came the Akin classification. So this is something came in the 2008, 2007 modification of rifle classification by Acute Kidney Injury Network, Akin. And they, from the point 5, they thought about that a small change in serum creatinine, maybe more than 0.3 milligram per deciliter, that would be also adversing the outcome of the patient. And it uses serum creatinine, urine output, and time. So this is in short. They have from 5 stages, they have changed to 3 stages: 1, 2, 3. And this is the serum creatinine criteria, urine output criteria, and the time criteria. Almost more or less same, but you can see it is in the percentage. Creatinine more than equal to 0.3 milligram per deciliter, or increase in the creatinine level 150 to 200% from the baseline. The second one would be 200 to 300%. Third one would be more than 300%, or same thing, creatinine more than equal to 4 milligram per deciliter with acute rise of at least 0.5 milligram per deciliter. Urine output, this is more than 6 hours, more than 12 hours, more than 24 hours. Same urine output criteria is almost similar to the rifle criteria. And if the patient is needing RRT, renal replacement therapy, they are classified as stage 3 straight, despite the stage they were before starting RRT. So if my patient is having creatinine of 0.9, but the patient is in severe metabolic acidosis with ischemic pericarditis with hyperkalemia, and I am now starting dialysis with the creatinine of 0.9 itself, straight I am jumping to the stage 3. So that is somehow we can label from now only one of the limitation of Akin criteria. Okay, we'll be discussing now in the next slide. So the criticisms to the Akin criteria, you can see here, creatinine to be measured within a 48-hour window, but that may exclude more slowly progressive etiologies. Maybe for the first 48 hours, the creatinine jump was not that significant, but within the next 24 hours, there was acute rise in, like, maybe sharp steep up, like rise in the creatinine. So that is, this Akin classification is not taking into account. Patients subjected to RRT are scored as stage 3, irrespective of the indication for RRT. This is one of the limitations I have already explained. There is significant variability in the local practice regarding commencement of RRT. So maybe in my ICU, I am having very low threshold for starting RRT. So the implication would be all my patients in whom I have started RRT, they will be all in the stage 3 in Akin. But maybe in your ICU, you are taking some time. You are using diuretics, you are using all conservative therapies. So your patient would be in the stage 1 or stage 2. So there is the variability is significant depending upon the local practice. And the scoring has been done in this study after optimal state of hydration. So they have used the term optimal state of hydration. But do you think this is something very clear in our clinical practice? This is a very ill-defined state of optimal state of hydration, keeping in mind we are not getting a very straightforward 20-year-old male patient with no previous comorbidity in our ICU. And we do not have the predictive acuity between the two systems. First the rifle, then the Akin. So maybe at this point of time, I would say this is also not well accepted. There are a lot of limitations, and I will give this talk. Okay. Now came something more, I would say, inclusive and that addresses many of the problems that we faced in the first two classification, that is KDIGO classification. And they have made it clear that we will be only involving serum creatinine, urine output, and here they will be again dividing into 1, 2, 3, and almost similar to that, but it is something they have tried to make simple for understanding. Now, in summary, some of the improvements that has been shown in KDIGO is a unified system to maintain the international coherence of research, and one has the freedom to use baseline creatinine if it is available, but it is no way essential. And KDIGO classification theoretically improved upon the limitation of the Akin criteria sensitivity. But there are certain criticism as well, that this unification of classification system only works if your nephrologist, your intensivist, everybody is in coherence. And we need to start thinking what is the etiology of AKI than only predicting that in which stage my patient is. So there is something we are still lacking. So maybe if I want to keep all the three classification for my undergraduate, my trainees understanding, you can see Rifle, Akin, and this is the KDIGO. And you can make it in the systematic way, RIFLE, Akin 1, 2, 3, KDIGO 1, 2, 3. Now, let's move to the other part, the second domain of our discussion. We need to think about what are the high risk population where AKI can develop easily. One is old age. Second one is diabetes mellitus, hypertension, CKD patient where you can have acute on CKD, and some of the obstructive uropathies. There are also, you can see, exposure factors. So if with the risk factors that I have already shown here, the population groups, if they would be subjected to this exposure in the form of sepsis, shock, any form of shock, contrast media exposure, some major cardiac surgery, and if we are starting with some of the nephrotoxic drugs, high chance of AKI development is there. So you can just remember, this is the high risk population, this is the risk factor or exposure factor, and this is the AKI development. Now, there are certain interventions we can do that would be reducing the percentage of patients going into AKI. That is, AKI, if we can early diagnose, we can adjust the drug dosage, change the drugs from the nephrotoxic to the non-nephrotoxic, volume status management properly, hemodynamic support if the patient requires, and also avoid nephrotoxic agent exposure. Now, what is the standard practice since age old? If we will be now going into the diagnosis with the lab thing in our mind, the diagnostic options right now available in most of the hospitals: increase in the serum creatinine, blood urea nitrogen, decrease in the urine output, period. So whenever we see this report in our day-to-day round, so we'll be thinking that this patient is in the AKI. So elevation is the serum creatinine is the current gold standard. But do you think this is the right approach? Now, how I will be trying to differ from you. If you start with the cardiology counterpart to the nephrology counterpart, from 1960, if we will be starting with the acute myocardial infarction, which is one of the important disease in the cardiology segment, and acute kidney injury, which is the nephrology section. So from 1960, if we will be discussing about the biomarkers, you see, they have started with LDH. In 1970, they jumped to CPK, myoglobin. 80s, it was CKMB. 90, it was TROP-T. 2000, it was TROP-I. Now it is like, no, there are many other like newer biomarkers as well. And with the background of these biomarkers, they have used multiple therapies, and the mortality has reduced significantly, almost to the tune of 50 to 70%. But if we will be now focusing on our nephrology counterpart, acute kidney injury, from 1960 till 2020, we are still believing the same age-old dogma, that is serum creatinine. And we do not have any specific multiple, like what we'll say and say the targeted therapy, just like acute MI, where we can go for PCIU, where we can go for thrombolysis at the right time, and the reduction in the mortality is significant. Rather, we will be only believing in fluid resuscitation, antibiotics, drug modification, and expect the miracle to happen in our patient. And as a result, what happens? The mortality is still significant. So this is the thing that we need to really understand now. So the limitations for creatinine, we all know from the Trini's perspective, this is a marker of kidney function, but that do not indicate the stress or injury of the tubular cells or structural changes happening within the nephron. So we really miss that important pivotal time with which, if we can diagnose or start treatment or start some resuscitation in that time, maybe the patient will not renal phenotypes of AKI and also the pathophysiology mechanisms. We all know creatinine can be influenced by non-renal conditions as well as medication. The most important is cimetidine. Now, the most you can say the argument that one can have against creatinine, that changes in serum creatinine become apparent only when the kidneys have lost more than equal to 50% of their functional capacity. So what we are going to do in that time? We are waiting for 51% to happen and then we will be starting our treatment. No, I don't think this is the right approach to our practice, at least in 2024. Then came the biomarkers which are better than creatinine. So biomarker based management of AKI. This was a very interesting article. You all can read this. Fact or fantasy? What is a biomarker? If somebody would be asking me, it is a characteristic that is objectively measured and is evaluated as an indicator of normal biologic process, pathogenic process, or pharmacologic response to a therapeutic intervention. So it has to serve three purposes. Indicator of a normal biologic process, something happening in the body as a pathology, that also it can measure. And again, if I am doing something, some intervention, that should be reflected by the change in the biomarker level. So what is an ideal biomarker? It is not existent, but that ideal biomarker has to be non-invasive. It can be easily, you can obtain that. You can measure it using standardized assays. If it is something fancy thing with some difficult gadgets, it will not be accepted. Fast results, you can get the report as soon as possible. Then only the validity of that biomarker will be there. And it would be incurring reasonable cost to perform. So if something of tune of in Indian currency, if we'll say 10,000 rupees each, maybe most of the ICUs, they will not be affording that type of biomarker. Now, this is the tip of the iceberg phenomenon. If we'll be looking at the creatinine only along with the urine output, then we are only looking at the tip of the iceberg here, clinical AKI. But if we'll be looking at the newer biomarkers, then definitely it would be taking care of the organ crosstalks, acid-base disturbances, electrolyte disturbances, the volume status, the bleeding diathesis, subclinical AKI, pseudo AKI, apart from the tip of the iceberg. So if we'll be going for the newer biomarkers, maybe the picture would be on the right side that we have seen. Now, what are the possible roles of the novel kidney biomarker? So it would help us in early diagnosis, help in the differential diagnosis, help in also prognosticate to the family, to the patient. In the early diagnosis, along with the detection of AKI, it would also help in the post-renal transplant when the patient is going for kidney rejection. It would also help me to predict that my patient post kidney transplant is going for the disease recurrence in the form of focal segmental glomerulosclerosis or hemolytic uremic syndrome. Coming to the differential diagnosis, I should be having the idea that my patient AKI is not simple AKI, whether it is a pre-renal AKI, renal AKI, post-renal AKI. Then what is the cause of acute tubular necrosis? Whether it is sepsis, whether it is IV contrast, whether it is post cardiac surgery, whether it is drug induced. Now, where glomerulus usually is the cause of I am getting some or other graft should have the guide me to prognosis to the family that yes, this patient may go for renal therapy later. Whether my patient who is AI is having both also the I am my or accepting that graft, or there is high chance of rejecting also. That also the biomarker should at least guide me. Now, this is the four quarter thing that you need to remember. From here, biomarker negative, creatinine negative, no functional damage, no structural damage. Biomarker negative, creatinine positive. That means functional damage is there without any structural damage, because structure means well biomarkers will be there increased. So that is the pre-renal where your will be high, but the biomarkers are not high. Now coming to the right side, biomarker positive here is there, but there is no loss of function. So this is subclinic AKI. Now biomarker positive, creatinine positive. So that is both the structure as well as the function are damaged. And this is intrinsic AKI. So if we'll be getting biomarker, it's not only AKI that we are diagnosing or detecting, rather the phenotype of AKI are also being like we are able to diagnose in our patient or detect in our patient. So this is the advantage of having the biomarkers which would be guiding us in treating. Now, I'm just saying at this point of time, there are more than 20 biomarkers available for the renal injury. And the urinary biomarkers are more non-invasive, easy to measure, easily obtainable, and they provide earlier detection of AKI. And that can be divided into stress marker, damage marker, functional marker, self-explanatory. Now, this is the picture you need to remember, or you can just take the understanding clear. There would be some or other biomarker increased synthesis in the extrarenal tissue that would be released from the circulating immune cells also. If there would be infection, there would be something like drug induced AKI, that would be all getting filtered here. As a result, what happens? There would be more of glomerular filtration of that biomarker, and that would be now entering. You can see this biomarker, there is impaired reabsorption in the proximal tubule. As a result, this will be flowing here, here, here. There would be increased synthesis in the tubular cells also. That is also infiltrating the immune cells from the surrounding peritubular capillaries also. And finally, what will happen? There is increased biomarker level in the urine. That will be getting tested, and finally we will be diagnosing that yes, my patient is in AKI. This is something in one slide, very interesting slide that was published in 2022 Nephron, the risk of complications, non-recovery, mortality, and healthcare cost based on the biomarkers. No kidney disease, then there would be stress and damage biomarkers. So you can make it subclinical AKI. Then there would be all this permutation combination that I have shown, the creatinine and as well as the functional as well as the structural biomarkers. You can divide your AKI into 1, 2, and 3. Finally, kidney failure. And these are something which you need to remember, that AKI has also some phenotypes like septic AKI. The management plan may be changed from the standard, like what we do in our ICU. Hypovolemic AKI, post-surgery AKI, heart failure AKI, nephrotoxicity or drug-induced AKI, acute on CKD, primary renal disease, hepatorenal syndrome, traumatic AKI, obstructive AKI, rhabdomyolysis AKI, and finally the inflammation AKI or cytokine induced AKI. So these are something you need to remember the AKI phenotypes. So in nutshell, if I want to summarize what are the biomarkers right now available, let's go into the markers of the glomerular function, markers of the tubular function or damage, and markers of the inflammation and repair. So this is just like no the classification of the biomarkers currently available, and you can see on the basis of different the domains of injury, you can get the different biomarkers, NGAL, cystatin C, then diagnostic markers also, then the prognostic markers also. Now, if we will be integrating everything, AKI resolution the green side and AKI progression is the red side. I have already discussed this before 2-3 slides. You can see if both the two things are negative, there is AKI resolution. If both the two things are positive, that means your patient is actually progressing further and this AKI is not getting resolved. So coming to the diagnostic workup, if I am right now diagnosed also, how to approach this patient. So I will be starting with dividing into three classes: pre-renal AKI, intriguing AKI, post-renal AKI. Let's start with the easy part, post-renal AKI. That means there is some obstruction, bladder obstruction, urethral obstruction. So I would be taking care of that with the urologist help, or like no, if I will be putting a Foley catheter, that is also an obstructive uropathy. Now coming to the pre-renal AKI on the left side, most important cause is reduced effective arterial blood volume due to hypovolemia. If my patient is in hemorrhage, there is skin loss, GI loss, renal loss. The second one would be reduced effective arterial blood volume due to relative, you can say, the hypovolemia. In short, relative hypovolemia, that means cardiorenal syndrome, sepsis, anaphylactic shock, hepatorenal shock, third space loss, or medication induced. Now, the third one would be arterial occlusion involving the renal vasculature in the form of your bilateral atherosclerosis of the renal artery or unilateral atherosclerosis. Now coming to the middle part, intrinsic AKI, you can divide into two parts: vascular disease, glomerular disease. Vascular disease, there are so many vascular disease, you all are very much familiar. You are treating day in and day out. Renal artery dissection, vasculitis, renal vein thrombosis, malignant hypertension, scleroderma. Coming to the glomerular disease, it is again immune complex glomerulonephritis or some or other like the pulmonary renal syndrome, vaginal granulomatosis, all these things. Now, the third one would be tubular disease. Interstitial disease is the fourth one. Now, coming to the tubular disease, it can be ischemic, septic, nephrotic. If I am getting a patient who is suspected to have acute kidney injury, what I will do first? First thing, record the review. What are the previous things that has happened that has resulted in the reduction in the GFR? Physically examine the patient, evaluate the hemodynamic status, go for the urine analysis and urine microscopy. Very basic test, but I think that is one of the most important, easy to do test where you can get the report at the earliest. Then determine the various urinary indices like FENA or fractional excretion of the urea. Put the catheter in and then measure maybe the post-boil residual urine volume if you are suspecting the obstructive uropathy. Fluid challenge in case you are suspecting pre-renal AKI, and go for some or other ultrasound, KUB to look for some obstructive features. And finally, if you are still not clear about the etiology of your acute kidney injury, go for kidney biopsy. If you are doing all these things in a very systematic way, most of the time you will get the etiology of AKI. Now, there are like a certain group of patients, the clinician face problem, how to approach a patient with oliguria. So all patients with AKI, they may have oliguria, they may not have oliguria. So if the patient is having oliguria, it can be pre-renal, intriguing renal failure or post-renal. So you have to decide how you are going to address that issue. Non-oliguric, it would be mainly intrinsic renal failure and post-renal. There would be hardly pre-renal component. So the absence of oliguria argues against a pre-renal etiology. So if you are getting like no oliguria, that means a pre-renal component is not there, period. But if you are getting oliguria, that reveals nothing about the etiology. So you have to think about pre-renal, intrinsic, and post-renal, all the things. So one clue for you to decide whether this patient is having intrinsic or not. Now, in the oliguria, again, the things have already been discussed, but you have to go in a very structured way. You are getting urine output less than 0.3 to 0.5 cc per kilogram body weight. Now, think about first thing first. Is there any urinary obstruction? Simple. Do the focus of the bladder and kidney. If you are suspecting that, yes, there is some problem, we are not putting the Foley catheter itself, then put the Foley. Then the problem is solved. If you are facing some problem with the kidney, the anatomical etiology, go for CT scan, urology consult, or flush the Foley catheter. If there is no urinary obstruction, check the hemodynamics with all the possible, like, the things that you have, the gadgets you have in your ICU at the bedside. Suspect hypovolemia, volume challenge. Suspect MAP inadequate, go for some vasopressor challenge. Suspect cardiac output is not there good enough, go for some inotropic challenge. Then if you are feeling that, yes, I am confused that whether my patient is actually congested well, but urine output is not there, then go for furosemide stress test. That is one of the very good diagnostic test also, I can say, FST. If you are getting good urine output, then continue to follow. If you are not getting good urine output despite all your evaluation that I have explained here, then you have to evaluate the other causes of AKI with some expert opinion. Now, FST, I think everybody knows about how to conduct FST. What are the indications of FST? So it has to be furosemide naive. If the patient has not received, then you have to go for like the 1.5 milligram. If patient has already received, then you have to go for high dose. If patient has not received, maybe you have to go with 1 milligram per kilogram. Then urine output more than 200 ml in 2 hours, you are happy. Patient has passed furosemide stress test. That is pre-renal oliguria. If it has not passed, urine output is less than 200 ml 2 hours, then intrinsic renal failure. So in short, if I would be just trying to finish this presentation, you have to first go for the history, physical examination, common lab findings I have already explained. Then you have to think about whether my patient is in the zone of pre-renal, zone of intrinsic, zone of post-renal. And then you have to also be very thorough. What would be your urine analysis? If it is ATN, you will get some of the epithelial cast, granular cast. If it is interstitial nephritis, you will get WBC cast more. Glomerulonephritis or vasculitis, RBC cast would be more. And if it would be some other vasculitis, you will get normal or few RBC. So this is something very basic, but we need to be very clear in our understanding about the urine analysis and also the diagnostic workup. In the final slide, if I would be saying, there is something called as AKI bundle. What is this AKI bundle? Discontinue all nephrotoxic agents when possible. Ensure volume status and perfusion pressure. Consider functional hemodynamic monitoring that would be repeated again and again. Avoid hyperglycemia. Consider alternatives to the radio contrast procedure. Then check for the changes in the drug dosing. Consider the renal replacement therapy. Consider ICU admission and avoid subclavian catheters. If still you are unable to control the AKI, patient is going into CKD, maybe that patient will need hemodialysis later on. So maybe you have to preserve the subclavian line at that time because you are going for fistula later on. So don't put the dialysis catheter in the subclavian line vein. So I think I have tried to compile the approach in nutshell, but still I know there are a lot of things which we can discuss and that would be going beyond, I think, our time limit. but one or two questions for the young talented minds. If I am getting the permission from the moderators, can I go for one or two questions?
Yes, yes, Tapas.
Okay,
You
we'll
can.
be completing
Absolutely.
with it. Yeah.
Yeah.
So the question number one, please all of you put in the chat box and we'll be taking this. This is very easy thing, but yeah, something like you need to remember or like the answer which I would be showing you. This is one of the urgent indication of dialysis. One of the urgent indication of dialysis. This is a trivia question. And this is the MRI finding. Can anybody tell me what is the diagnosis? Based on the MRI, I'm not talking about the clinical. Urgent indication of dialysis. If the patient will come with that diagnosis, you will be subjecting that patient for dialysis immediately. And this is the MRI finding. Anybody who has posted in the chat box? I'm not able to see. Okay. I will be giving you the answer. Don't worry. This is uremic encephalopathy. What you will get in the uremic encephalopathy? Uremic encephalopathy, we all know uremic pericarditis, uremic encephalopathy. This is one of the urgent indication of dialysis. And in the MRI, you will be getting symmetric involvement of the basal ganglia with hyperintensities, the arrows you can see, affecting the white matter that surrounds the basal ganglia, delineating the lateral and medial boundary of both putamen. So just remember, this is called as lentiform fork sign. You can see here. This is one of the typical thing that I got. I thought about like sharing with you. Now question number 2 is very easy. What is the first step in the initial approach to a patient with suspected AKI? First step, immediate initiation of renal replacement therapy, assessment of the volume status and perfusion, administration of high dose diuretics, maybe furosemide stress test, ordering a kidney biopsy. Easy, but sometimes we get confused what to do. The answer is B, assessment of the volume status and perfusion. First things first. Now, the last question, in the context of AKI, renal ultrasound is primarily used to measure renal blood flow, evaluate for post-renal causes of AKI, assess the renal size, determine the GFR. What would be the answer? Single best answer. We normally order renal ultrasound whenever we get any patient in our ICU suspected to have AKI. Why? To assess the renal size, or renal blood flow, or GFR, or post-renal causes of AKI. I think everybody will be right in their answer. This is to evaluate for post-renal cause of AKI. And final, like one question is there, so I'll be just completing. In urine analysis, muddy brown casts are most indicative of prerenal AKI, intrinsic AKI due to ATN, post-renal AKI, or chronic kidney disease. If you have sent the urine sample and the next day morning, you are getting the urine RE report coming as muddy brown casts. So what will be the most important thing that will come to your mind? Pre-renal, intrinsic AKI due to ATN, post-renal, and chronic kidney disease. It is intrinsic AKI due to acute tubular necrosis. I am just dot on, I would say, 50 minutes or so, but I tried to simplify the understanding of AKI. So hopefully, okay, you want to see the diagnostic workup? Yeah, sure, I will be sharing. Just a second. What I will do? Sorry. Yeah. So this is again interesting. If you have time, I can explain also. AKI, go for the full blood count, differential count, urine dipstick, urine microscopy, urine sediment.
It is
Renal
not shared
ultrasound.
till now.
Okay. Sorry.
Yes, please share this.
Okay, just 1 second. Can you see now?
Yes. Yes, it is visible now.
Yeah. Okay. So just look at this diagnostic workup. Very important. This is one slide solves all our problems. Whenever you have a patient in your ICU suspected to have AKI, go for the full blood count. We all do differential count. Go for one urine dipstick. You are thinking that you are having some or other diabetic ketoacidosis or something like that as your etiology. Go for urine microscopy, urinary sediment checking, renal ultrasound, serum calcium. There are some optional things that you can do: urinary electrolytes, urea, uric acid, osmolarity. This is the baseline investigations. If the cause of AKI remains unclear and hypovolemia and obstruction is excluded, or any of the investigations are abnormal, now consider the following investigation that you need to do. If you are thinking this patient is having glomerulonephritis or vasculitis, what will you do? Vasculitis, you will go for all the autoimmune markers. ANCA, PANCA, anti-GBM, anti-double stranded DNA, C3, C4, ENA, immunoglobulin, cryoglobulin. If your patient is suspected to have abdominal compartment syndrome, and that is the cause of your AKI, so you have to check with the bladder pressure. If you are getting TTP or HUS as your differential diagnosis, so in the peripheral blood smear, you will get fragment cells. LDH would be high, thrombocytopenia would be there, reticulocytes will be high, haptoglobulins will be low, and bilirubin will be high. Now, rhabdomyolysis, if it's the cause, CK, myoglobin. Everybody understands this well. Myeloma, most of the time you are not going getting the typical multiple myeloma picture, but you can send the serum or urine electrophoresis, renal biopsy, and calcium at that point of time will be helpful. You will get the hemoconcentration, anemia, calcium level to be very high. Sepsis, you will be sending anyway sepsis screen along with your blood culture, urine culture, and inflammatory markers. And cardiorenal syndrome, if you're thinking, go for the echo, the other investigations that would be supporting your NT-proBNP, CKMB, troponin, all these things. So this is something very clearly go like you can have your diagnostic workup. Okay, clear? Perfect.
I think there will be many questions, and this is a very, as usual, impressive presentation from Dr. Tapas. It is lucid, elaborate, and except the management part, everything is there in the menu.
Yeah,
I think
exactly.
we'll get Dr. Tapas in another time and have an management aspect of this AKI. And I think I have heard Tapas many times in a semi conference, but it is, I think the time here is better for these users to understand, or the trainees to understand what is happening in the acute kidney injury in the ICU. So with this, I think they can identify the hidden part of the iceberg, and we'll have a better outcome from the mm, ICU patients. Okay, the questions what we have in the chat box.
Yeah, I can
Uh,
also see. I am taking the questions. Yeah,
One
yeah,
is the role of diuretics in AKI.
yeah. So
Uh,
I have clearly shown to you furosemide stress test. You have to at least understand that my patient is responding to like your like the diuretics. If my patient is responding, that means it would be pre-renal. And if my patient is not responding to diuretics, then better you are like trying to hitting around the bush. You have to think about that my patient has already developed increasing renal disease or something which I am not able to treat with all these volume resuscitation, all these corrective measures. Pre-renal causes. Pre-renal causes are excluded if I am not getting the good response to the furosemide. And let's not overload the patient with fluid more, because anyway this furosemide is not working well with high dose of furosemide. So that is the best use of doing furosemide stress test at the bedside.
I think I want to add something
Yes,
to the
please.
question for Dr. Tapas, because many time in ICU we find the patient have a low blood pressure and having this type of AKI setting. So in that scenario, people are used to give furosemide stress test. Or what is your say about this? That means for as a
Yeah,
70 give 10 milligram, 20 milligram, but it is the dose for furosemide stress test is 1 milligram per
yes,
kg.
yes.
So how will approach in that
We are
scenario?
actually blaming diuretics, and we are using diuretics in a pediatric dose or neonatal dose, I would say, and we are not getting response, and we are blaming the diuretics. So better we should be understanding the concept of furosemide stress test. That means we are actually stressing the kidney with furosemide. That's why the name is furosemide stress test. But we are using only 10 milligram, 15 milligram. Some resident would be coming, the senior would be coming, okay, I can allow you to give 20 milligram. So that means he is doing some favor to that junior resident by just allowing 5 milligram more. So we are actually underutilizing the dose of furosemide. So I will agree completely with you. It's a like no very less dose compared to the body weight, and as per the furosemide stress test dose also minimum 1 milligram per kilogram. So that has to be given. Yeah.
So the take home from here is you should give an ideal appropriate
Yes.
dose if you want a furosemide stress test or you want a increase in urine output by giving Lasix.
Yeah.
The second question is a role of sodium bicarbonate in AKI, because many times they have an acidosis with an low, because the bicarbonate wants to compensate the acid held by the kidney. So the bicarbonate was many times around 10, 8, and there is acidosis. Should we give or should not we give? What is the take the answers from the expert.
Yeah, I know. If I will say no, I will hit many people's emotions with soda bicarb, because soda bicarb is so much penetrated into our clinical practice. So I would not say it is completely out of the box thing, but yes, it has no strong indication to use in AKI. But in some indications or some conditions where we can use soda bicarb, is one is the contrast associated nephropathy. There are certain literature they have shown that yes, if we are using soda bicarb along with N-acetylcysteine, so that has shown to be like preventing the acute kidney injury to like go into the little bit difficult stage. That is point number one. In septic shock patients, where you are getting the metabolic acidosis, severe metabolic acidosis with pH of less than 7.15. So in that condition, if you are getting your vasopressors to be having high dose and that is not responding, so definitely you can give soda bicarb. So that is one indication that as per the surviving sepsis campaign guidelines as well. But other than this routine use of soda bicarb just to increase the pH to a safer zone without the fluid resuscitation, without treating the etiology, without hitting the microorganisms with the correct antibiotic, is not a very ideal situation, because the side effect of soda bicarb, it increases the acidosis, the intracellular acidosis, and as a result patient will be hyperventilating. So one side effect is if the patient is not intubated and you are giving soda bicarb unnecessarily, so the compensatory mechanism is by the hyperventilation, and the patient will be trying at the disease condition try to hyperventilate and wash out the excess carbon dioxide. So that is not advisable in a very much frail borderline patient.
Okay, so the sodavector infusion you can use, but it with caution,
Yeah.
with treatment of etiology, and if pH is less than 7.15, and not give as an bolus, give as an slow infusion. That is what the final verdict. Okay. The next question is
One thing, Dr. Alok, in cardiorenal syndrome, diuretic has a strong indication. So let's make it very
okay.
clear. If your AKI is due to cardiorenal syndrome, maybe I will take another class, because recently I have taken cardiorenal syndrome. So in that, don't fear of giving diuretics if your blood pressure is also low. In that situation, the correct indication is you start noradrenaline, and then you can also give your furosemide, and that would be again very high dose in the tune of 160 milligram also. If you are your problem is with fluid overload, so don't fear with the last 6 dose at that time. Yeah.
The next question is, can new biomarkers detect AKI before deterioration of renal function? And
Yes,
how
yes.
about creatinine clearance and GFR?
Very nicely, if I will be sharing with you some article, these new biomarkers would be guiding you that yes, my patient is going into that stage before the clinical AKI. So that's the beauty of the newer biomarkers, that they can check or they can guide you in the subclinical AKI stage also. It is
So
clearly, yeah. Hmm.
actually issue is many times you get patient where you do not know if there is what is the previous creatinine, how is urine output hour before. So this, I think this new biomarker will help in that scenario. The next question, what is in the board chat box is approach to AKI, acute GE induced. That means acute gastroenteritis, I think, induced AKI, especially referred from somewhere. Onset of oliguria more than 10 to 15 hours. Sometimes, in spite of fluid challenge, no improvement.
Yeah. So difficult question. Maybe the 10 to 15 hours that you are getting the from the history is not proper. So 10 to 15 hours, maybe the patient was fluid depleted beforehand also. So ATN I think has set in, because with proper fluid resuscitation challenge also there is no improvement. So that means you have to now take care in the line of ATN, intrinsic renal problem, not the pre-renal. So in that condition, antibiotics, the other supportive hemodynamics, your blood pressure has to be maintained above your renal perfusion. So all these things have to be done rather than only fluid. So the essence of discussion, you have lost the time where you could have prevented the patient from going from the pre-renal to the intrinsic renal. Yeah.
So next is a compliment from I think Dr. Tadit sir. It is a marker interpretation with creatinine and output will be quite helpful if affordable. It will
Agree,
prevent
sir.
beating around the bush, and he has congratulated you also for a
Thank
great
you, sir.
presentation.
Thank you, sir. Thank you, sir. Tadi, sir.
And the next question is, few clinicians advise SBC, I think SBC plus diuretics in spite of anuria or oliguria
Yeah.
about the soda waker infusion.
Yeah.
And if all anuria or already there is an ATN sets in, I think at that scenario we may think twice before using it. Then one question is, can oral bicarb be given? I think that is many times people are using at soda bicarb tablet. I think there is an or to COPD patient on ventilator. Oh, it is a different aspect. Okay. So if it is in the question is, then I just change it somewhat. Can a patient with AKI can be given with oral soda bicarb tablet?
Why will be taking oral soda bicarb tablet for the mucolytic action? Why we are
No,
giving?
oral bicarb, I think they have some pH or I don't
I,
know because this
ideally
is
speaking, we should not be using oral soda bicarb for the patients on ventilator. If there are some strong indication, why we'll be using COPD patients on ventilator? So
okay.
I difficult to understand. Yeah. Okay.
So any questions you can all the viewer, all the participants can ask directly if you want to.
Yeah. So there are
If there is
certain
any
like
question,
direct messages also. Thanking also the team for organizing this class, as well as also praising the initiative. Yeah. Thank you.
uh, use of N-acetylcysteine in AKI. Last question, I think we'll take this.
N-acetylcysteine is in contrast associated nephropathy. If somebody has attended my class last week. It is available in YouTube in the Young Intensivist India. You can get little bit of indication of NSTL's
I
Okay,
their
think
role
the
of
questions will continue and
yeah, yeah.
continue. It's a fantastic topic and an excellent speaker this evening. And I think as Dr. Alok has suggested for the management, we feel that we can have another class. And I presume more and more questions for Dr. Tapas. And I request all the delegates who are joined directly, you can give a call to him also.